We're not going to get to the point that we talk about the meat and potatoes of this, which is how do you dose, and what are some of the questions, and what are some of the conditions that you might run into, and how do you treat them. So we're going to go to that second booklet, which is the thinner booklet, to talk about this. First of all, pellet dosing is really a medical art form. It basically, this unique art of developing the proper dose is something that took me years to develop, and which I have translated into a dosing formula, which takes a very short period of time to describe. It basically was the last piece of the puzzle that made the entire picture come together. Once the dosing formula was established and beta tested and basically shown to be beneficial, everything came together. So in talking about using this formula, it really relates to patient management. And in the first instance, when we're talking about premature surgical versus natural menopause, if the ovaries go into premature failure, or you have a bilateral oophorectomy done on that individual, it markedly impacts their physiology, because those folks that have their hormone production terminated prematurely have greater need for estrogen and testosterone. And the formula basically will take that into account, and it will be demonstrated by higher FSH levels. In addition to that, what we found even in males, young males, like after puberty, if they are hypogonadal, they'll need more testosterone. The patient who comes in who has to take high doses of hormone to stay symptom free is probably not going to tolerate a lower dose. And a lot of those patients are ones that have gone into menopause prematurely, or their doctors have put them on such a high dose for such a long period of time that their physiologic state will not allow you to use low doses. And so, as you can see in the second bullet point, the definition of high dose hormone replacement. As an example of this, a 58-year-old patient who's been on high doses of conjugated estrogen or patch estrogen will certainly need a higher dose of estradiol to restore normal physiology, not the lower dose. Same way with a 68-year-old patient. She may need 3 times the amount of estrogen that a woman who has been on no estrogen whatsoever for a 5 to 10 year period of time. So on the high dose hormone replacement, mark this page, because this tells you how to taper them off of the hormone. On conjugated estrogen, you want them to take a full dose of whatever for 4 days, and then use that full dose every other day for 3 or 4 doses. Because getting someone off conjugated estrogen is like trying to get them off of nicotine. The patient who is, like, say, on estradiol tablets, after 3 or 4 days, you can discontinue the estradiol tablet. Patches, for the patient on patches, which is all 17-beta estradiol, have them use 1 more week of patches. If they're on creams and gels, no matter what the dosage, those patients physiologically are not being impacted very much anyway. So have them use the cream or gel for 3 or 4 days up until the time that the estrogen is starting to show its effects, and they'll do just fine. There is a patient called a sensitive patient. This is a patient who comes in and discusses with you and tells you that they are sensitive to any number of medications. And what you do with this patient is that you feed back to them exactly what they just told you, which is I hear what you're saying, and since you are sensitive, we're going to lower the dose of your hormone to see, and this may mean that you may need a booster later on. What this does then is it basically creates a feeling of trust between you and the patient. Number one, that you've listened to what they said. Number two, that you're going to affect a plan that's going to be attendant to their needs. And thirdly, you've told them that they may, if they are not sensitive to what you're using, then they may need a booster, and they'll be willing to pay for that booster. So this is an example of that type of patient. This is a patient that I had. She went through surgical menopause. She had all the classic menopausal symptoms. She was sensitive to medication. Everything she reacted adversely to when it was given to her at high doses. Her FSH was almost 90. The estradiol level was low, and testosterone was non-existent. The formula would give you a dose of estradiol of 20 to 22 and testosterone of 125. My formula for the sensitive patient is to give them only 50% of what the dosing formula tells you to give them for estradiol and 25% of the testosterone dosage. Excuse me. Correction. Reduce their testosterone dosage by 25%. So you reduce the testosterone by 25%, and the estradiol dosage should be cut in half. And as you can see, once we treated her, she was sensitive. Her FSH went into the 20s, the estradiol level was normal, the testosterone level was excellent, and she said, "I feel fantastic. My husband is not keeping up with me sexually." Look at the dose we gave her. We gave her half of the projected dose of estradiol, and we reduced the testosterone dose by 25%. As I said, remember I misspoke on that first slide, it's reducing the testosterone dosage by 25%. And by doing that, you've created a patient for life. And remember, if in fact this dosage, this reduced dosage, wasn't sufficient for you, she's already accepted the fact that she may need a booster. Which would say, as we say over here, you can always give a booster if necessary. There's a patient I call a psycho patient. That's the patient that sits across from me at my desk, and I get this continually increasing nauseated feeling in my stomach because of the fact that I say to myself, I don't want to treat that person. And believe me, if that patient gives you that ache in your gut, if you put pellets in them, you're going to have an ache on your backside because of the fact that you're going to rue the day that you gave them pellets. If you don't feel comfortable with that patient, don't give them pellets. I would suggest using a sublingual troche twice a day, and whatever dosage you think is appropriate, and then have them back, get blood work in a month and have them back in 4 to 6 weeks, and basically see if in fact that irrational behavior has corrected itself. Because if it has, then you can use your original blood work to calculate a pellet dosage. I will guarantee you the patient who is basically altered psychologically will call you in 7 to 10 days, 2 weeks at the very most, and tell you that they're dying from what you're giving and they're having all kinds of problems. That patient, you basically do not put pellets in, and I would refer them to someone else because they will be an albatross around your neck. If a patient has visible scarring on their skin from old acne, or they tell you they fear acne, they fear acne being a problem with this, or they have active acne on their face, they need a reduction in dosage, and then you would activate the variable in the dosage formula that would basically take care of that acne or hair loss problem. And it will lower it 10 to 20% depending on which of those is present or if both are present. On those patients, please start them on spironolactone, 50 milligrams BID, in addition to using the pellets, because A, spironolactone reduces the 5-alpha reductase activity, and B, you will not get those symptoms exacerbating on any of those patients. Spironolactone is an excellent drug. First of all, it has a mild diuretic effect. Secondly, it spares potassium. Thirdly, it has almost no potential to adversely impact the liver. It is a safe drug, and it is a strong 5-alpha reductase inhibitor. In addition, in obese women and men, if they have insulin resistance, then you should use metformin as well. In patients with the uterine fibroids, please do not go any higher than 15 milligrams of estradiol, no matter what the FSH level states. And also, if the formula gives you a dosage of 16 milligrams, go no higher than 15. Always use 200 milligrams of progesterone in a patient with fibroids because those fibroids are more difficult to handle. Lastly, our cohorts and peers in Europe only use cyclic progesterone in their fibroid patients, and I found that reduces the incidence of breakthrough bleeding. If the patient is insistent on using a continuous progesterone so that she doesn't have a period, then be sure that you maybe even decrease the amount of estradiol to 12.5 milligrams. Because continuous progesterone in fibroid patients, more often than not, may result in some form of breakthrough bleeding. In the patient with benign prostatic hypertrophy, the usage of testosterone, according to the formula, it's built into the impact, on the dosage that activating that variable will be. So you just have to go to the formula and activate that variable. If there's if you have a patient that's bleeding and you're a non-gynecologist, read through this section very carefully. First of all, if it happens in the first 6 to 8 weeks, it was probably a pre-existing problem, and you need to be attendant to that and understand that there may be polyps, fibroids, there might be hyperplasia, there might be cancer, and you want to make sure, of course, that they took the progesterone properly. If she took it for 7 days and then discontinued it and she got bleeding, that would be the expected result. So make sure the progesterone was taken properly. But remember, in that first 4 to 6 week period of time, it may be a pre-existing lesion, and you have to make that diagnosis quickly. So you want to do a pelvic examination. You would think about an endometrial biopsy. You would get a sonogram. Remember that bar graph I showed you. You get luteal phase levels of estradiol in pellets. And luteal phase thickness is 7 to 10 millimeters, not 5 millimeters or less. If that endometrial thickness and they're not bleeding, let's say, and you're doing just a prophylactic transvaginal sonogram, if the thickness is 7 to 10 millimeters and it has normal vascularity, it does not have echoes, and it looks homogeneous, and they're not bleeding, that is a normal lining. A lining that has a lot of echoes, that has a lot of blood vascularity, and looks very irregular or heterogeneous, that's an abnormal lining and needs to be biopsied. A good study is doing a saline histosonogram, but do that after you do your biopsy. If the bleeding occurs after 8 weeks, you got to think about something happened with the progesterone. They didn't take it right, or you didn't give the right dose. So that doesn't excuse you from doing diagnostic procedures. So in those patients who are on, say, continuous progesterone, did they miss a dose? Is it instant release? If the patient continues to bleed on the continuous progesterone, she needs to be thought about, first of all, changing to her cyclic schedule. If she doesn't want to do that, then what you have to do then is tell her she's got to stop the progesterone immediately, wait for 3 weeks, have her take progesterone for 10 days, have her bleed off again, and then on the 4th day after starting that second bleed off, she can return to a nightly dose of progesterone, but I would increase the dose. Remember that patients that are if they use topical progesterone, they're going to get more breakthrough bleeding. Remember the proper dosage for 10 milligrams of estradiol or less. Remember the right dosage for estradiol of 12.5 or greater being 200 milligrams. If the bleeding does not resolve by doing these 2 simple bleed-offs, then you need to refer them if you're not a gynecologist or a family practitioner who isn't capable of doing a D&C or a hysteroscopy. So we come to the recheck. This is 4 to 6 weeks after the insertion of the full dose. and we look at the three scenarios. I ask you to review this time and again, at least once a week, so you become familiar with these. The first scenario is that the FSH is in the 20s or below. The hormone levels look great. The patient has improved, symptoms are great. Her libido may not be quite where you'd like for it to be, but don't do anything if their testosterone level is normal. In scenario number 2, the FSH has decreased 50%, because these are the patients who may have high FSHs, like 100, and it's come down to somewhere close to 50. Their symptoms are gone, and the hormone levels look normal. Just because the FSH is not in the 20s, don't do anything. If it's decreased 50%, you've done the right thing. It's in scenario number 3, where the patient is still symptomatic, the FSH has not decreased 50%, then you go to the dosing formula and you give them the appropriate dose of estrogen and testosterone depending on their symptomatology. So if they're still having hot flashes, or they're still irritable and their FSH hasn't decreased 50 or close to 50%, they need a booster. That's scenario number 3. In men, little different scenarios, but basically, and I would say to you that normal to high normal testosterone would be actually 900 to 1100. We need to change that 700 to 900. Don't do anything with them. They're okay. If they've reached 900 to 1100 in scenario number 2, but they've only had mild to slight improvement, the most common cause for that is either that they're still under a lot of stress, or they're just sitting on their duff doing nothing. They have to exercise to activate that testosterone. If you want to, repeat their lab work a week after you see them and see if in fact they're still there. And if they are, then they need to get off their duff. If they're not, if the levels continue to fall below normal, then you need to take them and get a booster. On scenario number 3, you didn't reach 700 and they're still symptomatic, go to the dosing formula, get the amount of booster that they need. The erectile dysfunction patient, it may take 6 months to improve, and you have to be upfront and tell them that, because the testosterone will improve blood flow, but still they may have problems medically, such as diabetes or hypertension, or the medications that they're using for that may have actual impact on their erectile function. And usually, if you educate them, they're going to be a very much more compliant patient. And tell them that the first sign of improvement is that they're going to start seeing a return of nocturnal erections. And you would encourage them to think about using Cialis 5 milligrams daily if their cardiovascular system allows them. If their cardiovascular system is poor, Cialis may not work until the blood flow really gets up there. Things that you're going to hear and how to fix them. I'm still tired. Well, you want to analyze their diet and exercise. Make sure that you correct it if it's inappropriate and inadequate. You want to make sure that their testosterone levels are normal. You want to make sure that that if in fact they have testosterone levels that are normal, like you see just above that, that you check the Epstein-Barr antibodies, because chronic fatigue syndrome is uncovered when you give patients testosterone and they still come in markedly fatigued. And you want to get the IgG and the nuclear antibody, not the IgM, although they will include that. The IgM tells you nothing. It's the IgG and nuclear antibody. And you'll find that over 9 out of 10 are going to have marked elevations. And we're going to talk about the treatment formula for chronic fatigue. If the testosterone levels are below normal, administer a booster, and the dosing formula will give you that. Here's an example of a female patient. She came in, we gave her the dose of testosterone and estradiol that was appropriate by the dosing formula. All her numbers came back great, but she was still very tired. We got Epstein-Barr labs. we found that our IgG was greater than 750 and that the nuclear capsid likewise was greater than 750. And so basically, when you find this, you've given the patient an answer as to why they're experiencing such fatigue, and the treatment for this is listed on this slide. You're going to recommend the health and wellness formula that we have, which has a lot of immune boosters in it. You're going to consider and inform them that they would benefit from B6, B12 injections, a half cc of B6 given with 1 cc of 1,000 micrograms per cc of B12. Use it twice a week until their energy returns, and then once weekly along with the health and wellness formula. Have them take Asian ginseng in the afternoon. Talk to them about stress reduction, improvement in their diet, such as using a diet high in fruits and vegetables and a Mediterranean-like diet. And if they don't want to use health and wellness, which has probiotics in it, then have them suggest probiotics to help improve their immune status. If they did well the first couple of times but not the last time, look for stress problems, look for Epstein-Barr antibodies. Also ask if they've added drugs or deleted drugs, such as discontinuing an SSRI completely. If it's due to stress, then you would want to use homeopathically 5-hydroxytryptophan, or it's found as 5-HTP, 100 milligrams twice a day, and SAMe, which acts as a serotonin reuptake inhibitor, 400 milligrams twice a day. They both go together to increase serotonin production. If they're under stress and they're already on an SSRI, then just use the 5-HTP, which is the amino acid that the brain uses to make serotonin. If they're having trouble sleeping, there's any number of homeopathic regimens. You can use any one of the three, 5-HTP, valerian root, or valerian itself, or melatonin in the doses indicated on the slide. If their hormone level's inadequate, be sure and correct them. Gaining weight, or I can't lose weight. This is not a weight loss therapy, and you have to be clear with them. This will help them be able to profit from the exercise and dietary regimen that they basically are using. So by improving their metabolic state, then they would be able then to see fat reduction. Not necessarily weight loss, but fat reduction, because it's not how much you weigh. You have to tell them, it's not how much you weigh that's critical, it's how much fat makes up your weight, because that's what's going to kill you. If you have a lot of fat, then that's what's going to kill you, not how much you weigh. And their cardio workout has to be increased in intensity to where they're huffing and puffing. Because if they're just walking down the street for an hour with their neighbor and talking to them back and forth, or talking on the phone, if they can talk on a phone or talk to their neighbor, they're not in the fat burn zone. They have to huff and puff to be and they need to do that. They need to do that without fail. The diet should be low in carbohydrates, low in fat, and be a multiple meal feeding. As indicated on the slide, they have to stop alcohol and white products such as white flour, white bread, and the like. And if they have insulin resistance because they got a big beer gut, or a woman has a waistline of greater than 34 inches, and if they have either hypertension or a dyslipidemia associated with that big belly, they've got metabolic syndrome, and they should be on metformin. The patients that I'm really concerned about are the patients that their memory and their thinking processes are not any better after about the second insertion. They need to be evaluated for dementia and Alzheimer's. If the gentleman is still having a problem with the erectile function, make sure that his medication isn't interfering. I bring this name Tongkat Ali to you because the Tongkat Ali is an Indonesian herb that is advertised on the web. I wouldn't recommend it. if they ask you about it, because of the fact that it's not only as expensive as Cialis or Viagra, but also it could come in contaminated. The other thing is that if you drive the estrogen level too low with the aromatase inhibitors, it may affect their erectile function, and all you have to do is stop the aromatase inhibitor for 6 weeks and then restart it if they're aromatizers at half the dose, like just a half a tablet a month of Femara. Are you ever too old for hormones? You're never too old. My oldest new patient was 95 years old. The do's and don'ts on the dosing formula are there. When we get to the dosing formula, you'll see them once again. I thank you for your attention to this presentation, and we will now go to the dosing formula for its explanation as to its usage. Thank you.